Good afternoon and welcome back. We shall now resume the afternoon scientific sessions. The next session is titled Clinical Conundrums. For chairing the session, may I now invite on stage Dr. Anup PP, Dr. Rachel Oman, Consultant Rheumatologist, Dr. K.M. Cherian, Institute of Medical Sciences, Chenganur. We request our chairperson to kindly proceed with the session.
Good afternoon. A warm welcome after a heavy lunch. So our first session will be by Dr. Srinath S., who's a consultant in clinical immunology and rheumatology at St. Gregorius Medical Mission Hospital, Paramila. He has major publications and major achievements. So I invite Dr. Srinath to take us over the session. So his session will be on monitoring lupus. Over to Dr. Srinath.
Good afternoon to all. First of all, I would like to express my sincere gratitude to the organizers for granting me this privilege of addressing this esteemed gathering. Being a post-lunch session, I know your attention span will be very low, as low as compliments during SLE flare. So we will just jump into the topic and rush through. So the topic is monitoring lupus. So first of all, why do we have to monitor lupus? That is because SLE is that one type of disease which can be very calm on a Monday morning, can be mildly angry by Wednesday, and by Friday evening it will ruin all our weekend plans by setting our house on fire. So that is why we always say, you don't treat lupus, you always babysit it. Okay, so it is one kind of disease which cannot be considered as a treat and forget kind of disease. It is a treat, track and trend kind of disease. It is very heterogeneous in its symptomatology. Different patients have different phenotype. The symptoms never match how the lab parameters work. So what we can only do is always track the trend and treat accordingly. The mortality rate, the 5-year mortality rate has come down to approximately 5%. It is never due to any magic drugs. It is never due to any revolutionary therapy. It's always because we have learned how to monitor the disease better. So what are we going to monitor? We have to monitor whether the patient is in remission, whether the patient is having a relapse. We will have to monitor the complications. We will have to monitor the damage and comorbidities as well. What are we aiming at by monitoring all these things? All the latest guidelines, EULAR 2023, ACR 25, and the Treat to Target Consensus Workforce 25, everyone says our target should be ideally remission. What is remission? We will come into it in a minute. If not possible, we are targeting a lupus low disease activity state. We don't want any severe flares. We want minimal steroids. We don't want any new organ damage, and the health-related quality of life should be reasonably high. So what is remission? So this is the criteria, definition of remission in SLE. DORIS criteria 2021, that is what we commonly use now in most of the studies. It says the SLEDAI score should be 0. The physician global assessment should be less than 0.5. It is independent of how the serology works here, and patient can be permitted on low dose steroids, antimalarials, even biological. So it doesn't matter what the serology is. You need a SLEDAI score 0 and the global assessment less than 0.5. That means the disease has to be quiescent or silent. The patient should be smiling, and the physician should be, or rheumatologist should be, trying to reduce the steroids. This is one side situation, which is an rheumatologist equivalent of spotting a unicorn, going to be extremely difficult, almost impossible. So that is why we are aiming at a lupus low disease activity score. Here the difference is the SLEDAI score needs to be only less than or equal to 0.4. Physician global assessment can be slightly higher, even up to 1. Steroid doses permitted up to 7.5 milligram per day. Even with LLDS, we can prevent organ damage and achieve better quality of life. So this is a minimum guarantee plan. This is in between remission and our pray to God. So this is a minimum guarantee plan. So why are we, once the patient is in remission, why are we again monitoring? We need to know whether the patient is going into a lupus flare. This is what we are all afraid about. What is lupus flare? It is the situation where the disease identified or suddenly remembers that it is lupus. It has to create some drama. So what happens? The SLE activity level will go from chill to chaos. There will be new symptoms or there will be worsening of new symptom. Complement levels will drop like stock market, like it is happening now. dsDNA will shoot up like a Bitcoin during a scam tweet. Not infection, not drug toxicity, not the patient's mother-in-law pestering him. It requires more steroids, more immunosuppressants, or maybe a deep sigh. So once these things happen, press the fire alarm and run. So this is a formal definition. Measurable increase in SLE disease activity with new or worsening clinical signs, laboratory parameters, or organ involvement, which requires treatment escalation in the form of steroids, immunosuppressants, or biologics. Only after exclusion of infection, drug toxicity, pregnancy-related changes, and metabolic or comorbid conditions. These are the symptoms, these are the organ-specific symptoms and signs which usually happen, but what I want to stress is there will be a fall in complement. C3, C4 levels will be low. There will be a rise in anti-dsDNA titer. ESR levels will rise. CRP is usually normal unless there is a serositis, arthritis, or vasculitis. There will be proteinuria, there will be raised urine PCR and active urinary sediment. Then, once there is a flare, we need to know whether it is a mild, moderate, or severe flare. If the joints are hurting, rash flaring, and ESR flirting, non-organ threatening, it is a mild flare. Moderate flare is when the patient starts Googling, is the lupus fatal, am I going to die? And the severe flare is one, the rheumatologist VP rises, there is nephritis and CNS involvement, a major organ threatening disease, that is severe flare. So we will look into certain organ-specific monitoring also. Kidneys are about which we are most afraid about. They usually don't shout, they only gossip. So what we have to monitor is urine routine, urine PCR, look for active sediments, serum creatinine, measure the BP, look for edema, measure the C3, C4 dsDNA levels, and if there is any discordance between the clinical findings and serology, you may even consider a repeat biopsy. The targets, there are so many guidelines, but in general, what we are aiming at is urine PCR less than 0.5 with a normal creatinine and inactive sediments in urine. This is the 2024 ACR guidelines on monitoring frequency. In SLE without lupus nephritis, you can quantify proteinuria every 6 to 12 months. If in a non-case of lupus nephritis, you should quantify at least every 3 months. Once there is sustained response, you can increase it to every 3 to 6 months. The target is sustained complete renal response. EULAR has also given some specific trajectory targets also. By 3 months, there should be 25% reduction in proteinuria, by 6 months 50% reduction, and by 12 to 24 months it should come down to normal. It's less than 0.5 to 0.7 grams per day. If these are not met, you should consider switching or augmenting the therapy. What about the brain? Whenever the patient has headache, it's never always lupus. It could be a flare, could be steroids, stress or relatives. Always treat the difficult one first. Start with the relatives. Look for new headaches, seizures, psychosis symptoms, MRI or angiography as and when indicated, and avoid attributing everything to lupus. Always rule out infection and metabolic causes. And for long-term survivors, cognitive dysfunction is a major problem. Always do cognitive assessment, which will improve their quality of life. Regarding joint, always, for every visit, ask the patient, is there any joint which is hurting? Do a clinical joint count, see if there is synovitis, see if there is chronic damage, see if the patient is having osteoarthritis, and if the patient has pain all over in almost all the joints, especially if he or she has a normal ESR, then you are welcome to the fibromyalgia zone. Think of fibromyalgia also. Mucocutaneous manifestations, skin lesions in SLE are a topic in itself which needs one full day. Look for new skin rash, photosensitivity, palatal ulcers. There is a plethora of skin lesions which can occur in lupus. I don't want to discuss in detail. What I want to stress is this thing. Class C, cutaneous lupus area and severity index. So the index is given here. The importance of this is class C can differentiate between activity and damage. So what is indicated by activity? Erythema, scaling and hypertrophy, acute hair loss, and mucous membrane lesions, whereas damage is indicated by scarring of skin, scarring alopecia, and dyspigmentation. For you to understand it a little better, see this patient who has discoid DLE lesion, discoid lupus erythematosus lesion. Here the activity is indicated by the erythema and the dyspigmentation indicates the chronicity or the damage. On day 56, after 56 days of antimalarials, what has happened is the erythema has come down, but the dyspigmentation has worsened. So basically, patient has improved. But if we don't know the difference between activity and damage, we will think of it as an active ongoing lesion and we will unnecessarily escalate the treatment. So that is the importance of class C, that is the importance of monitoring skin lesion. I need not tell any one of you here that there is an increased cardiovascular disease risk in SLE for various factors. You have to monitor both traditional and lupus specific factors. The traditional risk factor, even if it is normal, should be reassessed every 6 to 12 months. Check the BP, BMI, waist circumference, lipid profile, fasting glucose, HbA1c, ask if they are smoking, check their physical activity levels and see if the patient is going into menopause or premature ovarian failure, especially if she had received cyclophosphamide. There are lupus specific factors also. Measure and monitor the disease activity. Monitor steroid exposure. So cumulative dose of more than 10 grams will increase the risk markedly. Our target is less than or equal to 5 milligram per day. Whenever there is a renal involvement, that is a very high risk for accelerated atherosclerosis. Proteinuria, hypertension and CKD actually are, they are more important than LDL or lipid profile. Check the autoantibodies. If they are antiphospholipid antibody positive, they have an increased thrombosis risk. Reassess every 6 to 12 months. And there are certain specific tools we use for assessing the risk to classify the risk into low, moderate or high. They are the atherosclerotic cardiovascular disease pooled cohort equations. For SLE, we usually calculate it and multiply by 1.5 and there are other scores like Q risk 3. So they will basically classify it into low, intermediate or high risk. So this is what we have to do in SLE patients. Lipid profile 6 to 12 months, BP and BMI every visit, antiphospholipid profile every year, urine PCR and CKD assessment 3 to 12 months, steroid dose every visit you have to reassess and the risk scoring at least once a year. If the patient falls into an intermediate risk category, antiphospholipid antibodies positive, renal involvement, long-term steroid use, and if there is clinical suspicion, you may even consider carotid intima media thickness or even a CT coronary artery calcium score. If the CT CAC score is more than 100, the patient automatically get classified into high risk. What about monitoring of laboratory parameters? Blood. In SLE, falling counts, a mild leukopenia may persist in stable disease. Falling counts can represent disease, drugs, flare, danger, anything can happen. So the job is to differentiate it very quickly. Anemia could be due to iron deficiency, chronic disease, drug or even hemolysis. Whenever there is a rapid hemoglobin drop, go for an urgent hemolysis panel. Hemoglobin drops, complements are normal, think of drug more than disease. Whenever there is a persistent leukopenia, think of possibility of a systemic flare. Severe leukopenia, evaluate for disease flare, then check the medications, whether any of it is causing a bone marrow suppression, and see if there has been any recent viral infections. Chronic thrombocytopenia could be an indicator of antiphospholipid syndrome. Falling C3, C4 with falling platelets, think of flare. Pancytopenia, always rule out a macrophage activation syndrome. New lymphadenopathy, consider lymphoma and infections. Very high ferritin, macrophage activation versus sepsis is what we are thinking about. Thrombocytopenia, hemolysis and acute kidney injury, it is TTP or HUS, you need to take urgent action. So what to monitor each single visit? CBC with differential, retic count if the patient is symptomatic or if there is a hemoglobin drop. Check the peripheral smear, check LDH, bilirubin and Coombs test, and monitor the platelet trend also. Regarding pregnancy, I will just rush through. There are only a few points I want to mention about monitoring pregnancy in lupus. So it is almost like planning a mass mission, lot of checklist. One important thing I have to mention is that the golden rule is every pregnancy should be planned and patient should be quiescent for at least 6 months, 3 to 6 months. Then only the pregnancy is going to be safe. Pre-conception monitoring is the most important phase in planning pregnancy in SLE. You have to assess the disease activity and ensure that they are in remission for a period of time. Review the medication, let them continue the safer medications and let them stop the medications which are not safe. Hydroxychloroquine, azathioprine, low-dose steroids, cyclosporin and tacrolimus can be continued. Mycophenolate mofetil, methotrexate, leflunomide, cyclophosphamide might need a change in therapy. Always assess the autoantibodies before pregnancy. Raw and La antibodies have a risk of congenital heart block, and antiphospholipid antibodies, as you all know, has a risk of miscarriage, preeclampsia, and thrombosis. All other comorbidities, if possible, should be optimized before planning pregnancy. Their BP, their diabetes, their thyroid function, BMI, all should be controlled, and ensure that they have taken adequate vaccinations as well. During pregnancy, one important concern we have is differentiating between preeclampsia and disease flare. So this is what we have been taught from our UG days. In lupus flare, the C3, C4 will fall, dsDNA titers are bound to rise, there may be active urine sediment, other SLE signs may be present, normal uric acid, whereas in preeclampsia there could be a uric acid rise. There have been emerging diagnostic tool, a serum, FMS like tyrosine kinase 1 and platelet growth factor ratio. So this has been a powerful differentiator in recent studies. A high ratio is strongly associated with preeclampsia. Ratio is typically normal in active lupus nephritis, not very commercially available everywhere. So what if we have anti-Rho or antibodies? In the first pregnancy in anti-Rho positive mothers, the risk of developing a congenital heart block is 2%. Already someone with an affected child, in the subsequent pregnancy, the chances jump shoot to 18 to 20%. So every SLE mother who's having Rho antibody positivity, starting from 16th week, they should have fetal echocardiography, serial fetal echocardiography surveillance. If possible, every week until 26th week and thereafter bi-weekly. If at all you can detect first or second degree heart blocks easily, go for prompt maternal treatment with dexamethasone. CQ might even protect them in that aspect. And regarding the mode of delivery, we always prefer vaginal delivery, cesarean sections as per the obstetric indication. Timing of delivery usually 38 to 39 weeks. If there are other complications, you may consider an early termination. And there is a peak thrombosis risk in the postpartum period. And there should be mandatory prophylaxis for patients with SLE and APS. And during breastfeeding, ensure that they are on breastfeeding compatible medications. And after pregnancy monitoring, we are monitoring for complications in SLE, and the most dreaded one are the treatment-related complication. Of course, we are thinking about steroids, check for weight gain, blood pressure, glucose, development of cataract, skin changes, avascular necrosis, all these things, and think about other immunosuppressants causing bone marrow suppression, liver function derangement, infertility, bladder problems and all. So all these should be thought of during every single visit. Steroids are like credit cards, short term they are great, long term the interest rate is too high and should be paid in AV and diabetes. The goal is to be less than 5 milligram per day. How can we achieve it? Use hydroxychloroquine universally. Early steroid sparing therapy, belimumab and rituximab has shown good experience with steroid sparing, and never taper during active serology or clinical flare. Otherwise, you will be in for a ping pong match where you will reduce and then you are forced to increase, then you will taper, then you are forced to increase, it will go on. So taper slowly, gently, and taper like you are diffusing a bomb. And next, the complication we are most concerned about is infection. In fact, rather than lupus killing the patient, it is infection and atherosclerotic cardiovascular disease that kills the patient more. So to differentiate between lupus flare and infection, there have been so many things we have been taught all over. CRP is one such indicator. CRP is basically an interleukin-6 dependent acute phase reaction. In SLE flare, the interleukin-6 pathway is suppressed and we don't expect the CRP to raise beyond a level. except in case of serositis, vasculitis, or very prominent arthritis. In all other cases, CRP is likely to remain low, but in infection, it is likely to be very high. So an ESR CRP ratio might provide some clue. If the ratio is less than or equal to 2, more likely infection, more than or equal to 15 could be a lupus flare. Not always keep very high, very low threshold for suspicion of infection. So whenever in doubt, it is definitely infection. Treat for infection, check for blood cultures, do procalcitonin, check for occult foci of infection, do proper clinical evaluation. And these are the things we have always learned. During fever, C3, C4 normal, DSDNA normal, raised ESR, raised CRP, high grade fever, leukocytosis rather than leukopenia, raised procalcitonin, and there will be pyuria and bacteriuria in urine. So whenever in doubt, always infection. So how to do baseline infection screening for SLE patients? You do the viral markers, you assess whether they have TB or not, latent TB or not. You ensure proper vaccination status, see whether they have taken influenza, pneumococcal vaccine, papillomavirus, COVID and hepatitis B. Do baseline lab testing. If there is recurrent infection, check immunoglobulin levels also. And during every follow-up, ask the patient whether they have fever, whether they have cough, breathlessness, dysuria symptoms, skin infection, non-healing ulcers, lymph node enlargement, opportunistic infection. If we don't ask, they are not going to say. They will think it is unrelated to our disease, and they will think they will show it to someone else, and this will go unnoticed. So ask them at each visit, and there should be routine investigation. We should not forget CBC, urine culture, CRP-SR. So once CRP is high, infection is more likely. As I said, atherosclerotic cardiovascular disease kills more lupus patients. So metabolic monitoring is not at all optional. It is life-saving. It is most important than anything else. Lupus may not break the patient, but steroids are going to. So always monitor weight and BMI at every visit. Track the changes. Whenever there is a rapid gain, think of steroid toxicity. Significant loss, think of flare, infection, depression, GI toxicity. Blood pressure should be measured at all visits. The target is around 130/80. If there is renal involvement, it could be lower. Dyslipidemia, the usual lupus pattern is a low HDL, high triglyceride, reasonably normal LDL, but highly oxidized. Monitoring should be done every 3 months after starting or changing steroids, and once in remission, at least every 6 to 12 months. Bone health monitoring should be done. The topic was discussed yesterday. DEXA scan at baseline, repeat every 12 to 24 months if the patient is on steroids. Vitamin D levels to be assessed, PTH, calcium, phosphorus level to look for other causes, and assess for vertebral fractures. Do DEXA scan, do FRAX scoring, classify the risk, then treat accordingly. So BP every visit, weight and BMI every visit, glucose and HbA1c at least every 3 to 6 months, lipid profile at baseline and 3 months, DEXA every 1 to 2 years, vitamin D yearly, and atherosclerotic cardiovascular disease risk scoring should be done yearly. These are the red flag signs: new onset diabetes, severe hypertriglyceridemia, accelerated weight gain, sudden onset hypertension, steroid-induced muscle weakness, and bone pain due to possible compression fracture. You have to be on high alert. And after complication, the final stage, we have to assess the damage. We have to monitor damage. We have to know how much the disease as well as our treatment has together caused damage to the patient. So they are permanent scars of lupus and its treatment. What we commonly use is an SLECC ACR damage index. It has 12 components and almost all domains of SLE has been covered. You have to aim to keep this wheel as empty as possible and at least do the scoring once a year. And we have to differentiate whether it is lupus damage or treatment damage, or is it damage to the life itself. Damage is never the same as activity, and differentiation matters a lot to avoid unnecessary escalation of immunomodulator therapy. So what is damage? A non-reversible change which is present for more than 6 months since the onset of SLE, irrespective of the cause. It can be due to disease, it can be due to treatment, it can be due to intercurrent illness, but should not be directly due to active inflammation at that point of time. That is the only thing. So when you do the scoring, if it is 0, there is no damage yet, you can continue the same way. If the score is more than or 1 early in the disease, intensify the treat to target strategy. Aggressive steroid reduction may be needed, and tighter cardiovascular disease risk control If the SDA index is rising over time, then we are doing something wrong. So there is a failure of monitoring our strategy. Consider biological use, consider other steroid sparing agents, strong risk factor modification, consider rehabilitation, physio, vision support and all. Monitoring comorbidities, we already discussed, cardiovascular health, bone density, thrombotic risk, malignancy. Mental well-being is something we always usually miss. This is one thing that impairs the health-related quality of life a lot. Almost all the SLE patients will have at least 2 or more of anxiety, depression and sleep-related issues. So that should be addressed properly, otherwise our disease scoring will be wrongly shown as high. And treat the lupus and don't let the comorbidities kill the patient, as we already said. So all these things are not possible in a busy OPD schedule. All those are possible for study or research. So this is what I can recommend, a practical 10-point monitoring template for busy OPDs. Ask the patient how they feel. Ask the lupus how it feels. That is, do the dsDNA and complement. Ask the kidney how it is feeling. Measure blood pressure. Do urine PCR and creatinine. Ask the patient if any of the joints are hurting. Look at the skin, check CBC, review the medicines, ask them, are they truly taking it? Most of them will not be taking it at all, or they will be taking it as per their whims and fancies. Try to reduce steroids as early as possible. Check the weight and assess all other comorbidities and repeat this forever for that patient. So this is the practical 10-point monitoring template. And finally, these are my take-home messages also. The 5 commandments of monitoring SLE. Thou shalt aim for remission. If not, thou shalt settle for lupus low disease activity score. Thou shalt fear steroids more than lupus. Thou shalt check urine PCR frequently. Thou shalt prevent damage, flares, and unnecessary panic. So, the time may come when lupus may soon be curable. Until then, we should learn to monitor the disease smarter. Thank you.
Excellent presentation, Dr. Srinath.
Thank you, ma'am.
You made it very transparent for us. You left no stone unturned. And I loved your slides too. Very catchy.
Thank you.
So before I open it up for the rest of the crowd, so a patient who is clinically inactive, asymptomatic, but they have persistent leukopenia, mild leukopenia, with elevated dsDNA, how should we proceed further? Did we increase the immunosuppression, continue or same? How should we?
Not really. We will never treat the lab parameters alone. If the patient is truly asymptomatic and there are no other red flag signs, mild persistent leukopenia is common in stable SLEs. But along with that, if there is a fall in complement and rise in dsDNA, that could indicate an impending flare also. So rather than all of a sudden escalating the treatment, I will intensify my monitoring. So rather than asking the patient to come after 2 weeks or 3 weeks, I will ask them to come every week and just see they are fine or not. If at all there is if the patient becomes symptomatic, or if any other red flag signs develop, or if there is a falling trend, then I will be worried. Then I will be thinking about escalating the treatment actually. Otherwise, I will intensify the monitoring.
So any more questions? Then I think we'll proceed further. Thank you, Dr. Srinath. Sorry, Dr. Srinath.
In your slide, this one, do we need to repeat anti-phospholipid APS profile every 6 months?
Not really, sir. Only if it is a high-risk case, if we are thinking in lines of other clinical findings which could point towards an antiphospholipid syndrome, you can. If the patient doesn't have any such risk factors, once a year will be ideal. I don't know how practical it is. Will the patient agree to do it? Once a year is what generally the guidelines say. But at least once in 2 to 3 years, if you'll be able to do it, that will be good.
Okay, thank you. We shall move to the next speaker, Mr. Bhuvanesh. Bhuvanesh is a consultant rheumatologist at KIMS Hospital, Trivandrum. He completed his DM rheumatology from MMC Chennai and specialty certificate in rheumatology and MD medicine from EGI and MBBS from Amrita School. Over to you, Bhuvanesh.
Thank Chairperson for that kind introduction, and thank you organizing team, including Sukesh and Adish, for this invite. Okay, so the topic which is given to me is managing sarcoidosis beyond steroids. So what I thought was I'll give you 3 patient scenarios which most of us, more commonly encountered in our clinical practice, and I thought I'll start from there. The first patient I have titled as the incidental patient. So here is a 34-year-old gentleman, routine pre-employment checkup, completely asymptomatic. Examination was unremarkable. Chest X-ray is showing a bilateral hilar rhinopathy, scanning stage 1. PFT done, completely normal. DLCO is normal. So the question is, you confirm a diagnosis of stage 1 sarcoidosis, and what is the immediate plan? Do you start a patient on steroid? Do you start a patient on methotrexate? Refer for a endoscopic endobronchial ultrasound and the TBNA, or just observe the patient by mustard inactivity. The second scenario that we come across is something called as a steroid trap. A 52-year-old lady diagnosed with symptomatic stage 2 pulmonary sarcoidosis 3 years ago. The current status is that she reports her breathing is stable on a steroid dose of about 12.5 milligrams of prednisolone per day. However, in the last 2 years, she has developed all kinds of steroid toxicity, including a pre-diabetes, and a DEXA scan is showing osteopenia. So the dilemma here is, every time a physician or somebody tries to taper down the steroid dose less than 10 milligram, she has symptomatic worsening in the form of her cough returning within 2 weeks, and she has a functional worsening by FVC drop of around 5 to 7%. And she says she's terrified about, lowering the dose of steroid further. So here the patient is functionally stable, but receiving a good dose of steroid and is having significant glucocorticoid toxicity. So what is the next move here? Do you maintain the current dose? Do you aggressively taper the steroid because she's developing steroid toxicity? Do you bridge with a disease-modifying agent like methotrexate and then start tapering the steroid? Or do you switch to a biologic like infliximab? The third scenario that we come across is something like hidden symptom. You have a 40-year-old gentleman treated for pulmonary sarcoidosis 2 years ago. He presents with severe debilitating fatigue. He described it as waking up tired in the morning, describes some brain fog-like symptoms, and he says that it's affecting his IT job. His statement is that, "Doctor, last time I felt like this, you gave me steroids and I felt great. Can we increase the present dose of steroid?" He presently takes about 5 milligrams of prednisone daily. We did a workup. The workup is normal. AC is normal. Inflammatory markers are normal. HRCT shows stable fibrosis. There are no new nodules, no ground glass opacities, and PFT is stable. Though it is showing some moderate restriction, it is completely unchanged from the last year. So this patient is symptomatic in the form of fatigue, but has normal inflammatory markers. The imaging findings are stable. So how do you manage this patient? Do you increase the dose of prednisolone as per patient's request? Do you add a disease-modifying agent like azathioprine? You do not increase the immunosuppression, but you look for alternative causes of fatigue, or you do a PET scan immediately to look for occult granulomas or any other cause of fatigue. So these are 3 common case scenarios I think we all come across in our practice. And the aim of this presentation would be to, broadly how we should be managing these case scenarios in our practice. So broadly speaking, sarcoidosis is a disease which can affect literally any organ system in our body. So if you look at the most common organ manifestations of sarcoidosis, it is the lung, which is involved in about 90 to 95% of patients, followed by the lymphoreticular system. The lymph node enlargement is seen in about 50 to 60% patients. Eye involvement in the form of uveitis, it can be either anterior, intermediate, or in posterior uveitis, or there can even be a retinal vascular involvement. Hypercalcemia is another very common scenario that we come across in our practice. The range is very wide, with some studies even reporting up to 40 to 50% patients presenting with hypercalcemia. And small fiber neuropathy. So surprisingly, if you look at the data, about 50 to 80% of patients have some form of small fiber neuropathy. Some of them may be grossly symptomatic, and even some of them may be not very symptomatic. But apart from this, if you look at the most threatening or the organ threatening manifestations, that is in the form of cardiac involvement, which is seen in about 5 to 25% of patients, central nervous system involvement, which is seen in about 5 to 15%, and liver involvement, which is again seen in about 5 to 30%. So these are some of the dreaded organ complications of sarcoidosis, which cannot be handled very lightly by us. So obviously in the talk, I cannot concentrate on all these organ manifestations. So I thought I will concentrate on some of the most common and most organ-threatening manifestations and how steroid-sparing agents can be effectively used in them. So this is, a very familiar slide which all of us would have seen during our tenure sometime. So this is the staging of sarcoidosis. So stage 0 is absolutely no abnormalities. And remember, 5 to 10% patients of sarcoidosis can have absolutely no abnormalities on the chest X-ray. Stage 1 is only lymphadenopathy. That accounts to about 50% of patients with sarcoidosis. Stage 2 is lymphadenopathy plus pulmonary infiltrate. That accounts to about 25 to 30% of patients of sarcoid. Stage 3 is pulmonary infiltrates, which is seen at about 10 to 12%. And stage 4 is fibrosis, which is seen in about 5%. But any of this stage, if left untreated, can progress to stage 4. That will account to about 25%. So what I want to impress upon you here is, remember, if you have a cumulative percentage of stage 0, stage 1 and stage 2, that will account to around 80 to 90% of the sarcoidosis patients that you are going to see in your routine practice in OP. That is important, and I'll just tell you how that is important in the coming slides. So the first decision that you're going to take in the management of sarcoidosis is not whether to give steroid, is not whether to give disease-modifying agent, is to whether to treat the patient itself or not. Sarcoid is unlike other diseases. Rheumatoid, you know that you're going to treat the patient. Lupus, of course, you're going to treat the patient. But that's not the case scenario with sarcoidosis, because a good percentage of sarcoid patients go into complete remission. So the first question is whether to treat the patient or not. The statement that I have put here has paramount importance. The treatment is not indicated for a granuloma alone. You do a biopsy lymph node and you demonstrate a granuloma. We are not behind treating a granuloma, because there's absolutely no point in treating a granuloma in sarcoidosis, granuloma alone in sarcoidosis. So the basic decision to treat relies on two factors. One is, what is the danger that we are risking by not treating the patient? What is the risk of mortality and permanent organ damage if we don't treat this patient? Is this particular patient at risk of developing an organ-related problem? So that's the first question that we need to ask. The second is, what is the quality of life of the patient? Is the patient very symptomatic that he requires treatment? So the treatment is going to have a meaningful impact in his quality of life. So if the answer to any of these questions is a yes, then there is a prudent decision made to treat the patient. If the answer to any of this question is no, then there's actually no point in treating the patient at all. So like I told, asymptomatic or stage 1, stage 2 disease accounts for a large percentage of patients with sarcoidosis. And the point to remember in this is that about 70-80% of patients in stage 1 and about 50-60% of patients in stage 2, they go into spontaneous remission. Even if you don't give them any treatment at all, they're going to go into spontaneous remission. So do not expose them unnecessarily to steroids or other immunosuppressive treatment. So that's the dictum that we are going to follow in a patient who's presenting early stage 1 or stage 2 sarcoidosis. But it is very important to remember that a few percentage of these patients can progress or develop progressive sarcoidosis. So it is very important that we keep them under follow-up. So no treatment doesn't mean telling the patient go home, don't come back ever again. It just means that you're going to keep them under follow-up, monitor the PFE, monitor the radiology every 3 to 6 months. It just means that no immediate therapy is required for the patient from our side. So this applies to most patients with stage 1 and stage 2. But remember the rule that I gave you: if the patient is symptomatic, has severe cough, has debilitating fatigue, and if you feel that these problems are attributable to active inflammation because of sarcoid, you're still going to treat stage 1 and stage 2. But if you feel that those two problems are not there, then it might be worthy just to keep the patient under follow-up, even if it is showing active granulomatous inflammatory lesions in the lymph nodes. So grossly speaking, the indications to treat pulmonary sarcoid is worsening symptoms in the form of dyspnea or cough, a baseline FVC. This is a really wonderful parameter that you have in making a treatment decision. A patient with a baseline FVC of less than 50%, or on follow-up, if the patient's FVC or DLCO decreases by more than 10 to 15%, you know that this particular patient is progressing, and this is the patient who actually requires treatment. Or there are progressive radiographic infiltrates in the form of fibrosis or infiltrates. So those are again patients who would require treatment for sarcoidosis. So how do we treat? Suppose you have made a decision to treat sarcoidosis. Even now, most guidelines say that the first line therapy to treat sarcoidosis is steroid. But there has been a paradigm shift in the management of sarcoidosis. I'll come to that a little bit later. This is the age-old management of sarcoidosis. Here also, I think we need to keep in mind a few things. The first thing I would like to stress is the dosage of steroid. So there is enough and more data now to say that we need not treat patients of sarcoidosis with very high dose of steroid. 1 mg per kg, 0.75 mg per kg of steroid may not be required in most patients of sarcoidosis, especially patients with pulmonary sarcoidosis. We can get away with a dose ranging from 20 to 40 milligrams. Even if we look at our own Indian data, one study which was published from PGI Chandigarh called as the SARCOR study, it directly compared two dosing regimens of sarcoidosis. It compared between starting a patient on 20 milligrams of prednisolone and starting a patient on 40 milligrams of prednisolone. So what they found is that there is no major difference when it comes to the efficacy between 20 milligram and 40 milligrams of prednisolone. So it is, if possible, we always give a lower dose of steroid to a patient so that we reduce the overall cumulative toxicity of steroid. And the duration and tapering is not fixed. There is no fixed duration to treat sarcoidosis with steroid. What we need to do is a serial assessment. We need to keep assessing the patients every 4 to 12 weeks. And if responsive, we gradually reduce this dose of steroid and try to bring it down to a dose of less than 5 or 7.5 milligrams per day. Inhaled corticosteroids in pulmonary sarcoidosis do not have a major role to play if there is a parenchymal disease, but if there is an endobronchial disease or the patient is having prominent cough because of an endobronchial disease, in those subset of patients alone, there is a role for inhaled corticosteroids. So steroid even now remains as the first line therapy for management of pulmonary sarcoidosis. The second line agent, so we as rheumatologists, we are always, we have keen interest in giving patients disease modifying agents, and that's true for sarcoidosis also. So what are the indications to start a patient on a second line agent? So steroid refractiveness. Started patient on steroid for pulmonary sarcoidosis, not responding, so that becomes an indication to start the patient on second line agent. Or you're not able to bring down dose of steroid from 10 milligram or less, then that again is an indication to treat patients with disease-modifying agents. And here, the preferred disease-modifying agent still remains as methotrexate. So methotrexate is still considered as a gold standard agent in the treatment of pulmonary sarcoidosis. We do have other alternatives, people who cannot be given methotrexate for whatever reason. The alternatives would be mycophenolate mofetil, azathioprine, leflunomide, and hydroxychloroquine. But remember, hydroxychloroquine is primarily a drug which is used in cutaneous sarcoidosis. In most other scenarios of sarcoidosis, hydroxychloroquine does not have an important role to play. Moving on to the third line treatment, that is the biologics. And in the biologics, anti-TNF are the agents which have the most data. And even among the anti-TNFs, if you look at it, infliximab has the maximum data for use as a biological steroid sparing agent, which is followed by adalimumab. But most of the studies say that when patients are used on these biological agents, when we try to taper them off or we try to stop them, there are very high risk of relapses. So we need to be very careful when using these biological agents, and we have to be extremely careful when we are tapering or even stopping them. No rheumatology conference can go without, speaking about JAK inhibitors, especially tofacitinib, and that is true for sarcoid as well. So there are multiple studies. I don't want to, bore you with all these studies, but there are multiple studies which are, coming up with regard to tofacitinib in sarcoidosis. Please remember, primarily it is used for few indications. One is in cutaneous sarcoidosis, and second is in pulmonary sarcoidosis. So this is where we have maximum data, and the dose of tofacitinib is quite similar to how it is used in rheumatoid arthritis, that is 5 milligrams given twice a day. So present status of tofacitinib in pulmonary sarcoidosis is that it is generally considered as a fourth line or as a salvage therapy, meaning you have tried everything, you have tried your steroid, you have tried your conventional disease modifying, you have tried your anti-TNF, in spite of which the patient is not responding, then you can use tofacitinib as a salvage therapy. Or it can be used in prominent cutaneous involvement or patients with difficult to treat phenotypes, especially bone marrow sarcoidosis, refractory neurosarcoidosis. So these are some subset of sarcoidosis patients in whom we can use tofacitinib. So how do we monitor response to patients? So one, definitely we have to keep all these patients under our follow-up. We have to keep monitoring the responses every 3 to 6 months. And it is by a variety of things. One is clinical. You look at the dyspnea scores, the fatigue, how the patient's fatigue is. Then you look at the PFT. I feel PFT is one of the most important things, how you can monitor a patient of pulmonary sarcoidosis. You keep looking at their FVC, you keep looking at the DSCO. And imaging per se may not have a huge role, because remember, X-ray changes have a huge lag when compared to how the PFTs perform when it comes to monitoring. So this is something that I have taken from the European Respiratory Society guideline. So here there are so many things that they consider, but they consider 3 things as highly critical when you are monitoring a patient. One is the clinical judgment. So you see the patient and how you feel the patient is. That they feel is one of the most critical things in monitoring a patient. Second, like I already mentioned, is the pulmonary function test. And third is the monitoring the patient for the adverse effects of immunosuppressive therapies that we are using. So these 3 are the ones that they consider as the most critical things when it comes to monitoring a patient with pulmonary sarcoidosis. So this is, again, I have borrowed it from the ERS practice guidelines on sarcoidosis. This is for pulmonary sarcoidosis. So the most important thing that they talk about here is risk stratification. So for which I already gave you how do you stratify the risk initially. So you just group them into 3 groups. One is a low risk, second is an intermediate risk, and third is high risk. Low risk, never treat. We just observe them, we follow them up. We see how they do, and if there is only a progressive disease, there is an indication to treat. Otherwise, low-risk group patients are spared from giving any drug at all. High-risk and intermediate-risk patients are generally given first-line treatment as glucocorticoids, and those patients in whom we are able to successfully taper and stop, that will be the end of the story. But if you are not able to bring down the glucocorticoid dose, then only disease-modifying agents like methotrexate and azathioprine or mycophenolate is to be considered. And patients who fail these drugs, the third-line agent as anti-TNF can be tried. And patients in whom those drugs also fail, they advocate for JAK inhibitors. So JAK inhibitors are mentioned in some of these guidelines, along with even drugs like rituximab. But remember, the data for rituximab and JAK inhibitors in treatment of pulmonary sarcoidosis is very scarce. So what is considered as high risk? Patients who have baseline reduced FVC and DLCO, patients who have moderate to severe pulmonary fibrosis at baseline, and patients who have a pre-capillary pulmonary hypertension at baseline. So these are patients in whom you would directly, you would not even wait, and you would directly start the patient on glucocorticoids. And also, preferably also a steroid-sparing agent in the first visit itself. Moving on to the next most dreaded complication of sarcoidosis, which is a cardiac sarcoidosis. The problem with cardiac sarcoidosis is how do you make a diagnosis of cardiac sarcoidosis, because that itself is very difficult. Endomyocardial biopsy is, though it is a gold standard, it may not always give a diagnosis of cardiac sarcoidosis. The reason being the involvement of sarcoidosis in the myocardium is patchy. So when you do a biopsy, you may miss a portion of the myocardium where the sarcoid involvement is there. So patchy disease, almost, you may miss many cases by just doing a endomyocardial biopsy. So what is the clinical standard? The clinical standard is a objective imaging evidence of cardiac sarcoidosis along with a biopsy diagnosis of extracardiac sarcoidosis. So patient may be having a mediastinal adenopathy, may be having a cervical adenopathy. So you take a biopsy from the extracardiac involvement and you rely on imaging for cardiac sarcoidosis. So there are 2 investigations which are extremely important here. One is the cardiac MRI, and in that the most important parameter is the late gadolinium enhancement. Remember, it's a critical prognostic marker, meaning if there is a late gadolinium enhancement in the myocardium, it highly correlates with the risk of sudden cardiac death. So this is a very, very important parameter in cardiac MRI in patients with cardiac sarcoidosis. Second, we spoke a lot about PET today morning, so that becomes very relevant in cardiac sarcoidosis as well. So it is one of the best investigations for picking up active inflammatory lesions in the myocardium. The management of cardiac sarcoidosis is not very different from that of pulmonary sarcoidosis, but here, because of the considerable mortality involved with cardiac sarcoidosis, we generally do not wait, and these are patients in whom we often give high dose of steroid along with a disease-modifying agent. So this is not a stepwise approach that is generally followed in cardiac sarcoidosis. In cardiac sarcoidosis, mostly patients are treated with steroid along with a disease-modifying agent upfront. And here also, maximum evidence is only for methotrexate. And now there are upcoming drugs, including mycophenolate and anti-TNF, which are being used as first-line agents in the management of cardiac sarcoidosis. In cardiac sarcoidosis, the work does not stop with just immunosuppressive therapy. The reason being the myocardium is inflamed. So when the myocardium is inflamed, there is a risk of arrhythmias, and here the role of a cardiologist becomes extremely important. So there are, the most important thing is to prevent a sudden cardiac death. So here, in cardiac sarcoidosis, the threshold for implanting an ICD is much lower when compared to other causes of cardiomyopathy. So most of the cardiologists are uncomfortable with not implanting an ICD in those patients. So there are certain class 1 indications, that is a patient who has a sustained VT, or if the patient presents with a LVEF of less than 35%, that is a class 1 indication to do an upfront ICD in patient with cardiac sarcoidosis. Class 2A indications are if the LVEF is more than 35, but if the patient has extensive late gadolinium enhancement in the MRI. So that becomes a class 2 indication for directly doing an ICD in these patients. And indications for pacing is that if the patient has a high degree AV block, then that again becomes an indication for pacing. And in these patients, an ICD alone may not be sufficient, but they may also require a CRT device therapy. So all these decisions are to be taken as a shared decision between the patient, the cardiologist, and the rheumatologist. So I've just prepared this particular table as to how we practically manage patients of cardiac sarcoidosis in our OP on a day-to-day basis. So, in all patients of cardiac sarcoidosis in whom we are suspecting, we get imaging done, and preferably we do a PET and also a MRI in these patients. So if the PET scan is positive, and irrespective of whether the MRI is showing LGE lesions, the clinical status that we consider is that the patient is having active inflammation, because the PET is positive, remember. So here the focus of management is aggressive immunotherapy. So here we should predominantly give them high dose of steroid and also a disease-modifying agent upfront. We try to, postpone or avoid ablation at this particular stage, because the myocardium is very friable here. So immunosuppression first, and then go to ablation therapy is the dictum in patients who have very active lesions in the PET scan. The second scenario is the PET is negative. The PET is not showing active inflammatory lesions in the myocardium, but the MRI is showing late gadolinium enhancement. That is a stage of a fibroid or a burnt out disease. So here, actually, immunosuppression may not have a huge role. Rather, it is the cardiologist's role by doing a device management is what is considered as one of the best management for such patients. But many a times you will see patients who have active inflammatory lesions in PET and also MRI showing late gadolinium enhancement. So this is a mixed disease, and this is what we predominantly see in our clinical practice as well. So here mostly hybrid approach is required. We have to treat the patient with immunosuppression, and also device therapy has to be considered as indicated by the cardiology team. Next is the management of neurosarcoidosis. So here again a phenotype-driven approach is recommended. So there are low risk and high risk phenotypes. Low risk is a patient coming with isolated seventh nerve palsy. So those are patients who are unlikely to progress very rapidly or unlikely to develop central nervous system complications, or asymptomatic meningitis. So these are considered as low-risk patients. High risk is patients with optic neuropathy, spinal cord involvement, brain parenchymal lesions, or hydrocephalus. Management of neuropsychosis is not very different from that of other two types. Here also the recommendation is to give patients good dose of steroids, especially when they belong to the high risk group, and upfront disease modifying therapy is also recommended. So I'll just skip this for want of time. Okay, this alone I will say, this is one of the latest publications which has come out in the neurology journal. So here they have specified certain phenotypes of neurolupus in whom high dose of steroid and upfront anti-TNF therapy is recommended. So they are not even talking about a conventional DMARD, they are directly speaking about high dose steroid and anti-TNF. So those subset of patients are moderate to severe myelitis, patients with parenchymal disease and elevated ICP, patients with leptomeningitis and elevated ICP, symptomatic parenchymal disease in the form of focal seizures or generalized seizures, moderate to severe optic neuritis. And here the duration of immunosuppressive therapy is recommended for at least 1 year. Before I end my talk, I just want to, throw a little bit of light on how there has been a paradigm shift in the management of sarcoidosis. This is one of the latest publications which has come in NEGM. This was titled as the PREDMED study. The only question which was asked in the study is whether methotrexate as a standalone drug can be used in the management of pulmonary sarcoidosis bypassing steroids. So without giving steroid, can we manage pulmonary sarcoidosis only by giving methotrexate? So this was the primary question of this particular study. So this study had a significant number of patients, 137 patients. It was an open-label randomized controlled non-inferiority trial. So they just divided patients into two groups. One group received prednisolone starting from 40 milligram per day, and the other group received methotrexate starting from 15 milligram. And they had a follow-up of 24 weeks, and they looked at the pulmonary function test of these patients. So if you look at this, patients in whom prednisolone was used, there was a rapid improvement in the pulmonary function in the initial 4 weeks when compared to methotrexate. But when they looked at 24 weeks, there was absolutely no difference between the two groups. So what they concluded is that methotrexate is non-inferior to prednisolone in pulmonary sarcoidosis. In a significant number of patients, we may be able to avoid prednisolone totally and just give them methotrexate alone. And that is again, demonstrated in our paper. I would recommend that some of you go back and read this paper, which just came in the Lancet Respiratory Medicine Journal. Just want of time, I will skip. Okay, so this is one thing I want to stress. We are talking about steroids, but there are scenarios in which you can definitely not avoid steroids. One is cardiac sarcoidosis. Second is neurosarcoidosis. Sight-threatening uveitis. Again, you cannot avoid steroids. Severe hypercalcemia. Patients coming with calcium of 14, 15, of course you are not able to avoid steroids in them. And patients who come with acute pulmonary decompensation, you will not be able to avoid steroids. So going back to our case, this asymptomatic gentleman, the management would be just have a masterly activity or just observe the patient. Here the steroid trap is that when you're not able to bring down steroid beyond a dose, then definitely consider adding disease-modifying agents in those patients, and methotrexate is the key DMARD that has to be used in most patients with sarcoidosis. The hidden symptom here is that the fatigue. So the fatigue here is actually not related to any disease activity of sarcoid, rather it is because of other factors, so no point in increasing immunosuppression here. So we need to look at other causes of fatigue in patients who present. So the take-home message is that there has definitely been a paradigm shift in the management of sarcoidosis. We are slightly moving away from a steroid-centric therapy to a DMARD-centric therapy. Treat the right target. So we are not going to treat the granulomas. We are not going to treat the fibrosis alone. Rather, we are going to treat the symptoms of the patient, and we are going to treat the functional status of the patient. We, of course, need to monitor activity. The gold standard disease-modifying agent is methotrexate. In biologics, infliximab is considered as one of the drug of choice. JAK inhibitor, the new kid in the block, is reserved for few patients of sarcoidosis. And The red flag is that patients who present with cardiac, neuro, or vision-threatening sarcoidosis, kindly don't spare them of steroids. Give them the benefit of steroids in those patients. Thank you.
Thank you, Bhuvanesh, for an excellent, insightful talk. Forum is open for discussion. Yeah, please.
See, it's sort of an excellent talk, but what I want to tell is, in India, we don't get severe sarcoidosis, very rarely. I've got at present 4 patients with sarcoidosis, and we never start 40 milligram. All of them were started on 5 milligram. One is a doctor, he has already gone to remission, but the other 3 people, they are hard. I have even made it 5 milligram half daily. Hardly not much symptom or not much problem. That is what I have seen. I have not seen a cardiac sarcoidosis or other thing. But usually, we as a physician, we don't start 40 milligram. Unless if you very severely sick patient, 5 milligram itself is sufficient.
Sir, I would say that you're extremely lucky in not seeing patients with severe sarcoidosis.
This one. Some patients may, sir, most of the patients may be referring this one from the ophthalmologist, which having severe posterior uveitis and all. Yeah, there are different types of. So the whole thing depends upon what type of sarcoid you treat. Yeah.
What I'm telling is mainly it is sarcoidosis very in aggressive form in African blacks. Especially American African blacks, it is in aggressive. But otherwise, in India, I am practicing for the last 40 years. We don't see, most of the chronic cough, we try to, if there is a lymph node in the X-ray, we try to rule out sarcoidosis. It's not a very common disease also.
Maybe it's coming more to the rheumatologist. Anyway, great talk, Bhuvanesh. I just want, this perspective, it's not a question. So when we talk about the hierarchy of medication, 3rd line, 4th line, here there is a problem. Because if the hierarchy is best, if it is, we are going from oral to injectable, less costly to more costly. But here, the 4th line is a drug which is widely available, very cheap. So people would tend to jump from 2nd line to 4th line. Okay, and that is a real challenge we face.
Yes, sir, that's true. Even in other rheumatic diseases, we are facing the same challenges when many of them are being used on JAK inhibitors for probably no indication at all. I think that is an inherent problem with JAK inhibitors now.
Have you come across a case of paradoxical sarcoidosis induced by anti-TNF agents?
Induced by?
Anti-TNF agents?
Fortunately, no. Fortunately.
If there is no any questions, we'll wind the session. Thank you, Bhuvanesh, once again for that excellent presentation.
We are thanking Dr. Anup Pipi and Dr. Rachel Loman for chairing the session. Moving forward, we invite on stage Dr. Saeed Fahad Nizar, Consultant Rheumatologist, Aster-MIMS, Kannur, and Dr. Atul Pol, Consultant Rheumatologist, Bark and Came City Hospital, Calicut, for chairing the session. Request our chairpersons to introduce the speaker.
So our next speaker will be Dr. Anand Shashidharan. He is a senior specialist in rheumatology working at Aster-MIMS Protocol. So at the outset, I would like to thank the scientific chair for selecting this topic of pancytopenia, which commonly we used to encounter in most of our OPDs, but it has been seldom talked. Over to you, Dr. Anand.
Good afternoon all. So I'll straight away jump to my topic. So it will be an interactive discussion actually. So we'll be discussing the 5 most common causes of pancytopenia, which we usually see in our OPD or in the IPD cases. So to 3 cases, we go to the 5 main causes of pancytopenia we see in rheumatology. So, as you all know, pancytopenia, there is a simultaneous reduction in all the three blood cell lineages, hemoglobin less than 10, WBC count less than 4,000, platelet count less than 1.5 lakh. Mechanism of pancytopenia, it can be decreased production from the marrow, it can be increased destruction, or it can be sequestration in the spleen, or it can be ineffective hematopoiesis. Now, coming to case 1. So, this is a 28-year-old female with generalized tiredness, reduced appetite for around 6 months duration. She has been treated as iron deficiency anemia and vitamin D deficiency previously. Clinical examination, there was only pallor. So, we had to go to the investigations. So, here you can see hemoglobin is 7.6, MCV is 106, WBC count is 3,900, platelet is 35,000. ESR is 96, CRP is normal. Renal function test is normal and LFT showed indirect hyperbilirubinemia. So what are we dealing here? Anyone? So what the next set of investigation will do? Here actually we'll be dealing with something autoimmune. So we did a smear which showed features of hemolysis. DCT was 3+ positive. Coming to the autoimmune workup, there was hypochondroplasia with C3, low C3 and low C4. ANA was 3+ positive, homogeneous pattern. Blood was strong positive for dsDNA, nucleosome and histone. So this is a case of SLE with predominant hematological manifestation. Here we can see the patient only had on examination, there was only pallor. She didn't have the classical features like oral ulcers, photosensitivity, nothing. So from the hematological investigation, we came to the diagnosis of SLE. So with this, I'll come to the first cause of pancytopenia in rheumatology, that is a disease activity, mainly of SLE. In SLE, the cause of pancytopenia can be immune-mediated destruction or it can be bone marrow suppression due to high disease activity. So single-agent cytopenia or bicytopenia, that is the Evans syndrome, are more common. Pancytopenia is less frequent, seen in less than 10%. It's always important we exclude the infections. Management of such cases will be with pulse steroids followed by steroid-sparing agent. Initially, we can give MMF, azathioprine, or in severe cases, we can try IVIG and rituximab also. So this is the cause 1. Now, the same patient, she defaulted the treatment and again came to ER. Now, she has daily high-grade fevers, severe tiredness, and she was having very sick look. But clinical examination was normal. So, then we again, blood investigation is showing pancytopenia. Now, the counts have further decreased. Hemoglobin is 1,000, WBC is 1,500, hemoglobin is 6.2, platelets is 10,000, and there is alt liver enzymes. What is the next set of investigation you want to do? So, we want to know how the inflammatory markers are now. So, we can see ESR as 5 and CRP is 94 and ferritin is 20,000. Along with that, there is low fibrinogen. So, what are we dealing here? So, yeah, this patient has developed macrophage activation syndrome. So, this comes to the cause 2 of macrophage activation syndrome. So, that is the SLE can present untreated or severe disease can have macrophage activation. It's a medical emergency. If left untreated, it can progress to multi-organ failure. We all know the HLS criteria, but here the point is it's not imperative that the patient should have all the features. Like this patient on clinical examination had normal findings. There was no splenomegaly, low lymphadenopathy. There was only the cytopenia. So we need a high index of suspicion because it's a medical emergency. And features can overlap with disease fluorosepsis. The treatment will include pulse methylprednisolone, steroid-sparing agent, calcineurin inhibitors can be used, IL-1 inhibitors can be used, or IL-6 inhibitors. In refractory cases, therapies like etoposide need to be considered. So the point is, MAS should always be the differential when a rheumatology patient has unexplained fever, cytopenia, high inflammatory markers, but paradoxically low ESR. So the same patient again, the MAS was treated and she improved well. She was put on oral steroids, HCQ, MMF, and rituximab. Now the compliance is good. But she came to ER with 2 days history of cough. There is dyspnea on exertion, blood in sputum. There was some abdominal pain and diarrhea. There was no chest pain, orthopnea, PND, or wheeze. Pulse rate was around 102. BP was 100/70. There was mild tachypnea, respiratory was 24. SpO2 was 88 on room air. Blood investigation showed pancytopenia, LFT, RVT was normal, ESR and CRP was high, complement dsDNA levels within normal limits. What is the next investigation we'll do here? A bedside X-ray was done for this patient. It showed multiple homogeneous opacities scattered around the lung field. What are we dealing here? Yeah, this is a case of diffuse alveolar hemorrhage, as you can see here. So, is it SLE disease activity? Less likely, since she's on adequate immunosuppression and now the compliance is good. So need to consider the possibility of infections. In this case, the blood and urine culture is negative. 2D echo was done and it was also normal. So what are we doing here? We have to consider the possibility of some viral infection. So CMV DNA quantitative PCR was done, which was showing 26,200 rupees. So this comes to the cause 3 of infections, that is rheumatological patients on immunosuppressants are prone to opportunistic infections. Infections can directly cause bone marrow suppression or trigger hemophagocytosis. Atypical manifestation, that is fever may be absent. They have subtle symptoms like fatigue, mild cough or abdominal pain. Common pathogens to consider include mycobacterium TB, fungal infections, EBV, CMV and HBV reactivation. Management is mainly aimed at treating the underlying infection. So whenever there is a mismatch between patient symptoms and disease activity markers, consider the possibility of infection. Before ruling out infections, never escalate immunosuppression. This comes to the case 2. This is a 40-year-old female, symmetrical inflammatory polyarthritis of small joints of hands and feet with high ES and CRP. RF and NDCP was high, diagnosed as RA, and she was started treated with Folitrax, folic acid, CQ, and Defzacort. So after 3 weeks, danger. She lands at night in the ED with oral mucositis, tiredness, dysphagia. There was no arthritis, there was no history of fever or respiratory signs. Blood investigation showed pancytopenia and mildly deranged RFT. So who is the culprit here? The culprit here is this prescription. Here you can see Folitrax was given, the dose was also correct, but the timing, they haven't mentioned once in a week timing, due to which she was taking Folitrax daily, leading to something called the deadly methotoxic toxicity. So that comes to the cause for pancytopenia, that is drug-induced. Drug-induced pancytopenia can be seen patients on methotrexate. Overdosage is a serious issue. Bone marrow toxicity is dose dependent. Additional risk factors include hypoalbuminemia, concomitant use of trimethoprim sulfamethoxazole. It is life-threatening if untreated. The management includes stopping the methotrexate, leucorin rescue, that's 10 to 15 mg IV every 6 hours should be given, and it should be continued until clinical improvement and blood counts begin to recover. Along with that, adequate hydration is also very essential. So which is the other drug which can cause pancytopenia? Srinath sir already discussed this. So azathioprine. So reversible myelosuppression, this dose related can be seen with azathioprine. Low dose rarely results in immunosuppression. Severe myelosuppression is caused by low or absent TMPT activity or NUT15 activity. Low TMPT leads to accumulation of 6 thymine guanine nucleotides leading to myelosuppression. So it's how will you differentiate between azathioprine myelosuppression or SLE disease activity? Azathioprine related myelosuppression happens 2 weeks after starting Azoran, whereas the SLE disease activity can happen anytime. There is no hemolysis in myelosuppression, whereas in SLE disease activity, there will be hemolysis. Complements and dsDNA levels will be normal in azathioprine-related myelosuppression, whereas in SLE disease activity, there is hypochondroplasia and high dsDNA. ESR CRP is usually normal in azathioprine-related myelosuppression, whereas ESR is high and CRP is normal in SLE disease activity. So always associate the toxicity in a rheumatological patient on immunosuppressant, especially when there are no features of infection or disease activity. Education of patients regarding the correct dosage, especially for methotrexate, is very important. Now coming to case 3, this is a 48-year-old female, seropositive RA, well controlled on DMARDs, is now coming to your OPD with recurrent oral ulcers, low-grade fevers, and repeated chest infection. Clinical examination, there was no active synovitis, there was mild spleen, blood investigation showing hemoglobin of 9.8. The WBC count is very low, that is, the white count is 1,500 with ANC of 450. Platelet count is 150,000. What do you want to do next? Complements and dsDNA was done, it was normal. We did a peripheral smear which is showing some, what is this? So it's showing a large lymphocytes with some granules in it. Okay. So what is the diagnosis here? It's an example of a large granular lymphocyte syndrome which we see in RA. This is LGL syndrome is a close mimic of Feltis syndrome. So how will you differentiate an LGL with a Feltis? We'll discuss. So that comes to cause 5 of the pancytopenia. This is a Feltis. Feltis is a triad of RA, splenomegaly, that is more moderate to massive splenomegaly can be seen in more than 90% of the cases with leukopenia. It's seen in long-standing disease. RF and ANA can be positive. Rheumatoid nodules and artificial deformities are common. Extra-articular manifestation include chronic non-healing ulcers and bacterial infections. Low complements and HLA-DRB1 can also be positive. Treatment of choice is methotrexate. Now coming to what is LGL syndrome. In LGL syndrome, there is expansion of the LGL cells in the marrow and the blood. LGL cells can be cytotoxic T cells or NK cells. So these LGL cells will lead to severe marked neutropenia, which have we seen in our patient. This is the hallmark. Along with that, splenomegaly is less common than in Felty syndrome. So in LGL, there is a clonal cytotoxicity of T cell causing severe neutropenia and mild splenomegaly. Whereas in Felty syndrome, we are getting an RA patient with a moderate spleen and neutropenia. Here there is no clonal proliferation. So this is coming to the big 5 causes of pancytopenia in rheumatology. This includes disease activity, macrophage activation syndrome, infections, drug-induced, or it can be Felty syndrome. Thank you.
Any questions from the audience? I think Dr. Anand has covered most of it. So if any more questions, no more questions, we can close this session.
We'll be moving on to the next topic. The next topic is non-healing lower limb ulcers, and our speaker is Dr. Manish Manoj. He has completed his DM in rheumatology and clinical immunology from King George's Medical University and is currently working as a consultant rheumatologist in AKG Memorial Hospital and Baby Memorial Hospital, Kannur. Over to Dr. Manish Manoj.
Good evening, everyone. So I'll be speaking on this interesting topic, something that we see daily in our OPDs. Probably not daily, but very commonly, but which is very challenging in some cases. So what is an ulcer? Ulcer is a break in the continuity of the covering epithelium, either skin or mucous membranes, due to molecular death. A chronic ulcer is something which is an ulcer which shows a loss of epithelial integrity persisting longer than 6 weeks. It shows no tendency to heal after 3 or more months of appropriate treatment. So what are the causes for leg ulcers? As you can see, it's an extensive number of causes. Many of these have an acute presentation. Remember, this is not an extensive overview. I'm just looking at the causes for chronic lower limb ulcers, which are more rheumatology related. So why do we need to be alert in these patients? So the most important thing is that 15 to 20% of non-healing leg ulcers have underlying systemic disease. Vasculitis can account for 5 to 10% of these chronic leg ulcers. And there is a median diagnostic delay of 4 to 6 months in these patients, which may lead to irreversible tissue loss. So coming to this, a tale of 2 cases. On the left is a 22-year-old female with no comorbidities, with multiple recurrent leg ulcers of the bilateral lower limb since 3 years. And on the right, you have a 63-year-old male who is a chronic smoker, a previous bus conductor, with recurrent large ulcers on the bilateral lower limbs, mainly near the medial malleolus, since 12 years. So from these 2 descriptions itself, you have an idea of which patient probably has an inflammatory or a rheumatological cause for the ulceration. So when do you suspect vasculitis in patients? When the patient is young and has a non-healing ulcer, when the ulcers are rapidly progressive, that is within days to weeks it becomes large, when the ulcers have an irregular, undermined borders with erythematous, violaceous edges, when there are multiple and bilateral ulcers, both lower limbs, when there is an associated palpable purpura or there is a history of a preceding palpable purpura, and when there is extreme pain, where the visual analog score is more than 4 out of 10, which is disproportionate to the ulcer size. And when there is constitutional symptoms, such as fever, fatigue, weight loss, always think of a rheumatological cause. And when there is associated polyarthralgia or peripheral neuropathy. So what are the things that we need to know about patients with ulcers? Is one, ulcers are very unusual in large vessel vasculitis, both in giant cell arteritis and Takayama arteritis. Though in patients with Takayama arteritis, sometimes you can have panniculitis on the lower limbs. Usually, medium vessel vasculitis is associated with cutaneous ulcers. But in small vessel vasculitis, ulcers can occasionally occur when the lesions coalesce and impairs the cutaneous blood supply. In many cases, especially cutaneous pan is an exception. In many cases, patients can have an acute presentation, even though we are talking about chronic ulcers here. And an important point is that deficiency of adenosine deaminase 2, DADA2, which is coming in a big way in rheumatology nowadays, can present like cutaneous pain, especially in young children. What are the other features that suggest diagnosis of vasculitis in a patient chronic ulcer, chronic lower limb ulcer? One is purpura. I'm sure many of you must have seen at least one case of purpura. It's a very dramatic presentation. As I said previously, small vessel vasculitis does not usually present with ulcers, though it can present later in the course. Livido. This is a very nice livido racemosa picture here of this patient. And livido reticularis is a simple and it can be physiological. Livido racemosa is usually always pathological. And when it is associated with purpura, it is known as reticulate purpura. And then the shape and the undermined edge, which I mentioned earlier, irregular shape and an undermined edge. This is a picture of a pyoderma gangrenosum in this patient. So all these are other features suggestive of vasculitis. We can have non-vasculitic lower limb ulcers in rheumatology. One important differential would be anti-phospholipid syndrome, where the biopsy would show a thrombotic picture. In systemic sclerosis, ulcers can be big headache, especially when the patient has significant vasculopathy, and most of these vasculopathic ulcers are very difficult to treat. Also, you can have mechanical ulcers, probably due to contractures of the joints, especially seen in the upper limbs, but it can present in the lower limbs near the toes. And another important reason for ulcers in rheumatology that is non-vasculitic is calcinous cutis, which causes mechanical pressure and leads to ulcers. An important differential in patients with ulcers is pancreatitis. So I've just given a table which shows all the different types of pancreatitis, which is differentiated into predominantly septal and predominantly lobular pancreatitis. Usually, predominantly lobular pancreatitis with vasculitis can present with ulcers. Erythema nodosum, leprosum, Lucio phenomenon, neutrophilic lobular pancreatitis, erythema induratum, and Crohn's disease. But remember, cutaneous polyarteritis nodosa, which many of us see in our OP, is a case of septal pancreatitis with vasculitis. So some other conditions which can present with ulcerations in the rheumatology OP include pyoderma gangrenosum. It is a very important to diagnose these patients because immunosuppression might be required in these patients, which can give dramatic results. It is an ulcerative neutrophilic dermatosis, and it can be associated with IBD, hematological neoplasms, diabetes mellitus, and is seen in patients with rheumatoid arthritis. The Paracelsus score is used for the diagnosis, which is given on the side. And it usually presents as erythematous nodules or sterile pustules, which rapidly develop into very painful, remember, it is very painful ulcer, with dusky purple, partially undermined rims. Once you see one or two cases of pyoderma gangrenosum, you usually remember how it looks. Another important differential is a chronic tophaceous gout, which luckily in our place, because we start hypouricemics early, we tend to see a bit less. The moment you see a chalky discharge from the ulcer, always think of chronic tophaceous gout. But again, another important differential in this would be calcinous cutis, because an ulcer due to calcinosis cutis can also give a white chalky discharge. Another important differential in patients, especially with end-stage renal disease, would be calciphylaxis, which is a calcific uremic arteriolopathy. The average age of patients is about 60 years, 80% are women, and it is extremely painful. This is probably one of the most painful ulcers you can have. It is seen in end-stage renal disease due to abnormal calcium phosphate metabolism and can be seen when vitamin K antagonists are used due to inhibition of the matrix GLA protein. This can promote calcification and cause non-uremic calciphylaxis in patients without renal disease. The 6-month survival rate in these patients with end-stage renal disease is very low, around 57%, probably due to secondary infection as well. Another important differential in patients is nodular vasculitis or erythema induratum of basin. Erythema induratum is when nodular vasculitis is associated with tuberculosis. That is when you term it as erythema induratum of basin. In our country, because of the high load of tuberculosis, this is something that you should always keep in mind. A diagnosis is held with the biopsy, which shows granulomatous paniculatus and with vasculitis. Nodular vasculitis can be with idiopathic as well as associated with autoimmune condition. So in such patients, always work up for tuberculosis and autoimmune conditions. Another important cause for ulcers, chronic ulcers in the lower limb is Lucio's phenomenon, which is seen in lepromatous leprosy. Even though the rates is less nowadays, And Lucius phenomenon is actually less seen in India, but this particular patient is an Indian patient and had a retiform purpura, which you can see over there, along with chronic lower limb ulcers. This is due to the bacilli invading the endothelial cells. So how do we investigate a patient with chronic lower limb ulcers? The most important would be a skin biopsy. That would be probably the most important test in these patients. Then other tests that we would send would be ANA, ANCA, viral serologies, consider streptococcal antibodies in some patients, RF anti-CCP, complement levels, serum cryoglobulins, serum protein electrophoresis, and malignancy screening in the correct population. And for systemic involvement, always think of a urine analysis, complete blood count, a complete metabolic profile, a chest X-ray depending on the symptoms, a stool occult blood test, and vascular assessment is also important, especially Doppler ultrasound, ankle brachial index, which is very important in evaluation of patients with arterial and ulcers, and arterial imaging to exclude ischemic etiology. So coming to the skin biopsy, which I mentioned earlier as one of the most important ones, you should take the biopsy from the edge of the fresh ulcer or from an early purpuric lesion. It should include the subcutaneous tissue. As I said earlier, medium vessel vasculitis is the most common cause for chronic lower limb ulcers in rheumatology, and you miss the medium vessels if you don't get enough depth of the skin biopsy. At least a 4 to 6 millimeter punch is preferable. Ideally, it should be an incisional biopsy, and it should be done ideally within 24 to 48 hours of the lesion appearance, especially in small vessel vasculitis. It has only 50 to 80% sensitivity, so you might need to consider repeat biopsy. There's something called telescoping biopsy, in which a second punch biopsy can be performed in the defect created by a larger punch biopsy. As you can see in the middle here, it helps you to reach the subcutaneous tissue and helps in diagnosing medium vessel vasculitis. Next, about management. This is just an overview. The first thing would be looking at the etiology of the ulcer and medical and surgical management of the ulcer, appropriate referrals for the comorbidities, and then the local management of the ulcer, which includes local management of infection, debridement, the environment of the ulcer, the use of compression, reperfusion methods, and then the patient requirements, especially pain, lifestyle, and social determinants. So I just wanted to mention this particular paper here, which has an excellent review of treatment of ulcers, including the physical components. Coming to the basic overview, in cutaneous small vessel vasculitis, as we know, we usually use azathioprine, colchicine, MMF, and systemic corticosteroids in a low to medium dose. In severe refractory patients, you can use cyclosporin, rituximab, infliximab, as well as IVIG, depending on the presentation. In pyoderma gangrenosum, it has been divided into mild and moderate or severe presentation, where mild is less than 3 ulcers, less than 3 centimeter, and moderate is more than 3 ulcers or more than 3 centimeter. So in mild, topical treatment is enough. Probably our dermatology colleagues will help. And in moderate severe, you might need systemic corticosteroids, which are given as first line. Cyclosporin does a good job in many patients. Even infliximab, TNF inhibitors, others, ustekinumab, pofasnib, anakinra have all been tried. Remember, in pyoderma gangrenosum, using sharp debridement can lead to a pathology phenomenon causing worsening of ulcer. At the same time, the possibility of pathology should not prevent you from doing a biopsy to confirm the diagnosis. So coming to livedoid vasculopathy, that is an important differential in patients with chronic lower limb ulcers. It is due to permanent changes in the vasculature. The first line would be anticoagulation and antiplatelet agents. Second line would be danazol, which is an anabolic steroid. They do use IVIG, TNF inhibitors, and as well as BAC inhibitors in patients with severe livedoid vasculopathy. As I mentioned earlier, antiphospholipid syndrome, anticoagulation, and low-dose corticosteroids can help. In systemic sclerosis, when I mentioned digital ulcers, it is basically endothelin antagonists and PG analogs with aggressive local wound care and addressing the Raynaud's phenomenon. But again, I mentioned earlier, vasculopathic ulcers are very difficult to treat in patients with systemic sclerosis. So what are the keywords that you should look at in a skin biopsy? When it comes to vasculitic ulcers, the use of fibrinoid necrosis of the vessel walls is an important term. Always look for that in the biopsy report. Extravasation of red cells also can suggest a leukocytoblastic picture in skin biopsy. In a livedoid vasculopathy, fibrinoid material in the vessel wall. Remember, it is not fibrinoid necrosis. It is fibrinoid material in the vessel wall and subintimal hyalinization, which is seen in later courses of the livedoid vasculopathy. In calciphylaxis, there is vascular media calcification. In pyoderma gangrenosum, there should be dense dermis neutrophil infiltration and endothelial swelling. Venous ulcers has an abrupt transition from normal epidermis to the ulcer. This is called a step sign. So what are the take-home points? One, lower limb ulcers in rheumatology are more commonly multifactorial. Both arterial, venous, and inflammatory factors contribute. Remember, in a patient of rheumatoid arthritis coming with ulcer, probably venous ulcer is the most possible cause. Then look at the demographics. I mentioned earlier in the tale of two cases. Always look at the demographics. We give you an idea about what the cause for ulcer is. Timing of biopsy is very important, especially in cutaneous small vessel vasculitis. A lack of response to immunosuppression, even in patients with rheumatology cause for ulcers, can be due to secondary infection. A simple swab culture might help. And remember, in difficult scenarios, always take help from your pathology, dermatology, and plastic surgery or surgery colleagues. Thank you.
Thank you, Dr. Manoj, for that excellent presentation. One question, is there any role for topical JAK inhibitors in vasculitic ulcers, at least as an adjuvant agent?
As of now, there's not much studies on that. There are not extensive studies, but there have been case reports where some resistant ulcers have improved with topical JAK inhibitors. But data is still scarce.
We can now take up questions from the audience.
Thank you.
Is there any long-term follow-up available on this? So my question is, whether these patients who are having chronic skin ulcers, do they sort of, convert into frank systemic vasculitis as the time goes?
So when you mention that, I would probably first think of cutaneous pan, which you would be thinking about whether they would go on to develop systemic symptoms later on. But probably the data is, again, it is only case report and anecdotes. So there's not much data that, this much percentage of patients will go on to develop systemic involvement. But it's probably more important to pick up these patients early and treat them sufficiently so that you don't give it a chance to develop a systemic manifestation. Thank
you. Am I allowed to ask a question to Anand? Anand, that second case was very good. So the methotrexate was being given daily. My question for the benefit of all of us is, how much folic acid would you recommend to anybody who's receiving methotrexate every week?
Ideally, it will be, we have to give around 10 mg, sir. So the usual practice is, if you're giving methotrexate on a Monday, the next Tuesday and Wednesday you give 5 mg. Or we can give OD dose Monday to Friday. Like the next day you take methotrexate, like that.
Any more questions? We can officially conclude the session.
Before we end, I just want to thank the Calicut Rheumatology team for putting up such a great show, both academic as well as gastronomic. A special thank to Anufka for that. And it has been a great experience, and thank you for this opportunity. Thank you.
Thank you, sir. So once again, thanking our chairpersons, Dr. Saeed Fahad Nihar and Dr. Atul Por for chairing the session. So that was the last topic from the scientific sessions.